Okay, so I'll be talking to you about new insulins and specifically next generation basal insulin analogs. This is the outline of my lecture. I'll talk briefly about the role of insulin in type 2 diabetes and the challenges of insulin treatment, the limitations with previous basal insulin therapy, and the development of next generation basal insulin and how they compare to first generation basal insulin, and then a comparison of the next generation basal insulin to each other. So we all know that the pathophysiology of type 2 diabetes is actually not only insulin resistance, but also insulinopenia, where before the diagnosis of type 2 diabetes, actually patients will have increased insulin resistance and a compensatory increase in insulin secretion by the pancreas. But by the time of diagnosis of type 2 diabetes, actually insulin secretion will go down. And it has been found that by the time of diagnosis of type 2 diabetes, actually 50% of the pancreatic function is lost. And that decline actually is progressive, as you see. So what's the role of insulin in type 2 diabetes management? As I said, type 2 diabetes is a progressive disease, and many patients eventually will require intensification of therapy from oral antidiabetic agents, where basal insulin therapy is a cornerstone of type 2 diabetes management for patients who do not achieve control with the intensification of oral treatments. However, there are psychological and behavioral considerations associated with insulin treatment from both the perspective of the patient and the physician that may result in basal insulin therapy being frequently and inappropriately delayed. So as you see in this study that in spite of escalating HbA1c, it takes over 8 years for insulin therapy to be initiated, and many studies actually showed an average of 9.6 HbA1c until insulin is started, where the patient will spend this journey for many years from diet to exercise to monotherapy, combination therapy until insulin is started and having long duration of uncontrolled diabetes. So what are the challenges to optimal insulin therapy? And this brings the term of clinical inertia, which means whenever the healthcare provider does not initiate or intensify treatment appropriately when therapeutic goals are not reached. And in type 2 diabetes, the main clinical inertia we see is the initiation of insulin. And that's due to challenges that are faced either by physicians or patients. So main challenges that are related to physician is the side effects of hypoglycemia and weight gain as major side effects of insulin treatment, and the time and resources that the physician needs to start patients on insulin, and of course the burden of insulin titration. And in regards to patient concerns, adherence and burden of being on insulin treatment is a concern, and the fear as well, where fear of needles or fear of the side effects, and the perception of insulin therapy as a failure or a punishment for not taking care of their diabetes illness. And of course, multimorbidity and regimen complexity also plays a role in patient-related concerns. So it's not only initiating insulin, but also despite being on insulin, patients are still not in control, where low number of people with type 2 diabetes treated with insulin are achieving glycemic control. This is a large-scale real-world study of around 40,000 patients found that the majority of patients did not achieve a target of HbA1c of less than 7 in the first 3 months or after 2 years following initiation of basal insulin treatment. And after initiation of basal insulin, the delay in escalating titration have been contributing to the suboptimal glycemic control. Studies also found that there are high rates of discontinuation often occur shortly after insulin initiation. This study looked at the first year after basal insulin initiation and found that only 20% of patients continued insulin treatment regularly, and 60%, the majority, had one or more interruptions defined as a gap of 30 days or more, and 20% actually discontinued insulin. So, and most of the treatment interruptions and discontinuation actually occurred in the first 3 months. So what are the limitations with previous basal insulin therapies that played role in these challenges? Actually, it's the administration that has to be at the same time every day, the variability of the glucose-lowering effect, and the duration of action that may not always last 24 hours. So it's mainly adherence issues and hypoglycemia issues. So in terms of adherence, this is a global internet survey of patients and physicians' beliefs regarding insulin therapy. And these are the responses of patients regarding insulin doses being missed or not taking as prescribed. And these are the reasons the patients mentioned, like being too busy, traveling, skipped meal, stress and emotional problems, embarrassing to inject in public, and forgetting taking the dose. What about hypoglycemia? Hypoglycemia also continued to be a problem with the previous basal insulin analogs. In this study, you see the percentage of patients who reported having at least one self-treated hypoglycemic event in the past 30 days, where it showed that 25% of patients on basal insulin will have hypoglycemia. Is that important? Yes, because hypoglycemia hinders up titration to target, where the concern over hypoglycemia may cause people to modify their insulin dose. In this study, as you see, 4 in 10 patients who had mild to moderate episode of hypoglycemia actually modified their insulin doses to avoid future hypoglycemia. And for those who had severe episodes, actually 6 in 10 people modified their insulin doses. And hypoglycemia concern is not only related to patients, but also to physicians, where hypoglycemia may prevent healthcare providers from setting more rigorous targets for insulin therapy, where studies found that 4 in 5 specialists report they would be more aggressive in treating diabetes if there was no concern of hypoglycemia. So how we can overcome treatment inertia and appropriate insulin initiation? Of course, patient concerns should be managed through education, and a personalized treatment approach should be used, but also we need an ideal basal insulin to meet all challenges, where we need longer duration of action to control fasting blood glucose with 1 injection per day, and flat time action profile with lower risk of hypoglycemia and less day-to-day variability for lower hypo and hyperglycemia. And here where it comes the novel agents that addressed insulin barriers we've just mentioned, where I'll be talking about the next generation, or called also the second generation basal insulin analogs, mainly insulin degludec and insulin glargine 300. In this slide, you see the developmental milestones of insulin. And in this year, we are actually celebrating 100 years on the invention or the discovery of insulin, where in 1921 was invented from dog's pancreas. And then it keeps progressing until the year 1982, where the first human insulin was introduced with a recombinant DNA technology. And in the year 2000, the first long-acting insulin analog, glargine 100, was introduced, followed by insulin detemir. And in the year 2015, second-generation basal insulin analogs were introduced. So how do next-generation basal insulin compare to first-generation basal insulin? Insulin degludec, where the addition of a hexa amino acid actually allowed for the formation of a multihexamer in subcutaneous tissues after injecting, and this allowed for the formation of a subcutaneous depot that results in slow insulin release into the systemic circulation. And actually, there are 2 formulations in the concentration of 100 and 200 unit per ml. And in regard to insulin glargine 300, compared to glargine 100, there is a more compact and a microprecipitates, resulting in a reduced surface area, which will lead to slower release from the depot surface. So as you see here, this is the pharmacokinetics of different basal insulins, starting with NPH in the red line here as an intermediate acting basal insulin, as you see, with a peak and short duration of action that will not last more than 16 to 18 hours, and that will require actually twice daily dosing. And then you see in the blue lines, insulin glargine 100 and insulin detemir, the first generation basal insulins. as you see here, with the more flat profile, and may last for 24 hours, but sometimes even less, and sometimes may be needed in twice a day dosing, especially with insulin detamir. And if you compare them to the next generation basal insulin, insulin glargine and insulin degludec, where you see longer and more stable pharmacokinetics and pharmacodynamics profile than the first generation, with low within-day variability and high reproducibility in insulin exposure, and predictable and stable glycemic control well beyond 24 hours. So how would they compare to the first generation? They are equally effective in lowering HbA1c and have longer duration of action. With insulin degludec, it's estimated to cover around 42 hours, and with insulin glargine 300, around 36 hours. This would allow once daily injection and greater injection time flexibility, where with insulin degludec, the interval of between injections approximately 8 to 40 hours between doses, and with glargine 300, there is an injection time window of plus minus 3 hours. There is also flatter action profile and more stable pharmacokinetic profile with reduced glycemic variability and lower risk of hypoglycemia. And of course, these characteristics may help overcome patient and physician concerns about insulin use in type 2 diabetes management. So now I'll be talking about the clinical trials regarding these two next generation basal insulin, the BEGIN trial, which is about insulin degludec, and the additional trial for glargine 300. Both of these trials actually are phase 3A clinical trial programs that compared the efficacy and safety of these next generation basal insulins with the first generation basal insulin glargine 100 in a broad range of adults with type 2 diabetes. So actually these programs consisted of many trials with a broad range of patients, whether on basal bolus insulin, on basal insulin alone, or insulin naive and a newly started insulin. So just briefly a comparison here between the two trial programs. As you see on the left side, and in the BEGIN trial, where I'll be first talking about the difference in HbA1c. So patients showed a slightly better outcome in HbA1c with insulin glargine 100 versus insulin degludec, whereas in the additional trials, the overall analysis of all the trials showed a comparable and same effect in terms of HbA1c difference. What about hypoglycemia? As you see here, the relative risk of confirmed or severe hypoglycemia in the BEGIN trial, patients on insulin degludec had a comparable hypoglycemia compared to glargine 100 for any time of the day or the 24-hour hypoglycemia, but had better outcomes and less hypoglycemia compared to glargine 100 in terms of nocturnal hypoglycemia. So for insulin degludec, there was a difference between anytime hypoglycemia and nocturnal hypoglycemia. However, the additional trial showed that glargine 300 consistently had better outcome with, in terms of hypoglycemia compared to glargine 100, whether for any time of the day hypoglycemia or nocturnal hypoglycemia. So we conclude from this trial that insulin degludec 100 and glargine 300 demonstrated similar HbA1c reduction to glargine 100, but with less hypoglycemia in people with type 2 diabetes. So that was comparing the next generation basal insulins to first generation. But what about these two? How do they compare to each other, the two second generation basal insulin analogs? And here where I'll be talking about the BRIGHT trial, which is the first head-to-head randomized clinical trial designed to compare the efficacy and safety of glargine 300 with insulin degludec 100 in participants with type 2 diabetes inadequately controlled with oral medications. So this is the study design, where it was a multi-center open-label one-to-one randomized trial. As you see, after screening, patients were randomized to receive either glargine 300 or insulin degludec 100, both once daily. And the treatment period was divided actually into titration period, which is the first 12 weeks, and followed by the maintenance period for another 12 weeks, and patients were followed after the study end of 7 days. The study looked at the primary efficacy endpoint, which is the change in HbA1c from baseline to week 24, and the secondary efficacy endpoints were the change in fasting plasma glucose, which is venous, and the fasting self-monitoring plasma glucose, and the 8-point self-monitoring plasma glucose profile from baseline to week 12 and week 24. What about the safety endpoints? Mainly here speaking about hypoglycemia. The study looked at the incidence and annualized rate of confirmed hypoglycemia over the full study period and the titration period and the maintenance period separately. So briefly, the results of the BRIGHT study showed non-inferiority of glargine 300 versus insulin degludec 100 in HbA1c reduction at study end. So as you see, they were comparable and the same, and both reduced HbA1c from baseline. And of course, as you see, the dramatic decrease was in the titration period, as expected. Similarly, with the fasting plasma glucose and fasting self-monitoring plasma glucose, it were reduced similarly in both study arms. And again, similar 8-point self-monitoring plasma glucose and variability profile at baseline and study end for both arms, insulin degludec and glargine 300. What about hypoglycemia? As you see here, we are looking at the incidence and the events rate of hypoglycemia for any time of the day hypoglycemia or 24-hour hypoglycemia. If you see, the first row shows the hypoglycemia rates in the full study period, the second row showed in the titration period, and the third row in the maintenance period. And as you see, the hypoglycemia was comparable for both arms except for the titration period, where insulin glargine 300 had lower rates of hypoglycemia compared to insulin degludec. Similarly, with nocturnal hypoglycemia, the incidence and events rates of hypoglycemia for both arms were comparable, and there was a slight better outcome or less hypoglycemia with the glargine 300 in the titration period. So we conclude from the BRIGHT trial that in previously insulin-naive people with inadequately controlled type 2 diabetes, glargine 300 and insulin degludec provide similar glycemic control accompanied by comparable hypoglycemia during the full study period and maintenance period, with less anytime hypoglycemia for glargine 300 during the titration period. So the BRIGHT trial have provided useful clinical information to facilitate the choice between basal insulins. And now finally, I will conclude my talk with this slide, where the advances of these next generation basal insulin can be translated into clinical practice, where second generation basal insulin analogs are appropriate for the following patient scenarios. For a new basal insulin start in type 2 diabetes, where the BRIGHT study suggests that glargine 300 would be the preferred second generation basal insulin analog due to the potential for less anytime hypoglycemia during the titration period. And for currently taking twice daily basal insulin, where the long half-lives of both of these insulins would allow to the conversion to once daily dosing. And for currently taking basal insulin and experiencing or suspecting of having hypoglycemia, and for patients desiring smaller volume insulin as glargine 300 and insulin degludec in 200 concentration offer less volume options. And finally, for patients requiring increased flexibility of insulin dosing, where insulin degludec has been shown to be safe with the flexible dosing in type 2 diabetes ranging from 8 to 40 hours, whereas with the glargine 300, it has only demonstrated safety with plus minus 3 hours. Thank you for listening.